I mean, what are these technologies you find helpful that they talked about?
I've heard people, we personally don't use it.
Right. I was getting to you. Yeah. I use the smart nav. That's all.
Just pass it around.
Check.
I use the smart nav just from an ASC standpoint. It takes away the need for a post-operative image with the C-arm, which is never that good anyway. And the smart nav allows me to know. I'm a 6'3" guy, like I mentioned yesterday, and it allows me to know if there's tip rollover. And I get impedances for my audiologists and NRTs, which is very helpful. It does. That's part of the feature is that it will detect a tip rollover.
I've played with the smart nav. We don't own one. Our hospital is currently not buying straws for our drinks, let alone equipment. But I play with it. Actually, it's beautiful. It really shows you a nice kind of a heat map looking thing, so you can see if your electrodes are folded over. That's how it does it. It's basically looking at the sort of cross electrode impedances. I use the intraoperative electrocoagulography for almost all of my hearing preservation advanced bionics cases. I use the lateral wall array. I don't know yet what the electrocochleography tells me necessarily. I think it's really cool to play with, and I think it's neat to see the post-insertion audiogram, and I think it's neat to get the feedback about how slow maybe you need to go, or do you need to change the orientation. But we meaning the people who have written this stuff up in the journals, haven't shown that electrocoagulography predicts anything. So I think there's a lot of data out there that still needs to sort of be collected. I do not use the Med-L Otoplan, but I have found, speaking to angular insertion depth, that for the SSD population, I use almost exclusively a flex electrode, which is 31 millimeters, which kind of comes out their nostril and goes back into their hip. It's so long. But I find that the match between the normal ear and the deaf ear, the longer you insert, I think does have some substantial benefit to sound quality in the implanted ear because it more closely approximates the spectral resolution. So we're actually part of a Cochlear SSD study right now, and we're doing all 632s, and they haven't really studied. A lot of Cochlear's old data was with their sort of lateral electrode, the 622, and I think it'll be interesting to see, getting close to the medialis, even though it's a little bit shorter, can you more closely approximate some of the spectral resolution? So that'll be interesting to compare a long lateral wall to a shorter perimedielar, but they're all neat.
Andrew, what do you think? What do you use?
We'll get a post-op. My implants are not in the ASC yet. Just from financial, we still have things to work out with that. I do a post-op x-ray, but we'll do the cochleography. My problem with that is that there'll be reasons why it doesn't work. Well, this electrode doesn't work, and so I can't tell you how many times they said, well, it's okay, everything's all right, we'll do more testing post-operatively. And it doesn't really correlate with that. I've also been told, I don't know if it's changed, that someone could actually put it in the wrong place and you still could get the right, NRT or NRI, and so, okay, what am I really learning from that? And so, I mean, there's some practical, and then there's the theoretical with that. I think this is just my opinion about the insertion speed. So I vibrated the mastoid. Now I violated the inner ear, and at least in my hands, I think there's some people like DeBakey could do things in heart surgery. I trained in Houston. There's things he could do that other humans couldn't do. I just have a hard time in my brain wrapping around that after I've done all that traumatic stuff to the cochlea, that just a few seconds different is going to make that much long-term difference in the preservation with that. And at least in my practice, if, again, like I said yesterday, if they have that hearing, that's not the person that I'm not going to, for me, with that.
Cliff, what do you think?
I would say it depends a little bit on where I'm. So I'm at the at a veterans hospital where we have a little bit more flexibility with some things. So in that setting, we often do intraoperative. We do NRI after monitoring. I do post-operative x-rays or intraoperative x-rays for everybody to check positioning, both to check the depth of insertion, but also as a reference in case there's any change at some subsequent point where we need it as a reference. In terms of the intraoperative, like the ECOGs intraoperatively, for patients that have residual hearing, like I think I would kind of agree with Dan. I'm not sure what it means yet, but I think it's very interesting, and I think it's kind of fascinating to see what effects very subtle changes in hand position or the speed you're inserting can make on a response. So kind of back to what Andrew said is, well, we know these subtle things are actually making a difference. We don't know the long-term impact of that, but my feeling is we want to do everything as gently as possible anyway, because we're implanting more and more people that have some residual hearing. So I think I certainly have patients with any one of the manufacturers that has had good preservation of hearing. So I think it's not really a question necessarily of specific electrodes sometimes. You can put in one of some of the older, pretty big electrodes. Sometimes we had excellent hearing preservation. I don't know why. But I think kind of just being aware of the subtleties of your technique is probably always important for learning how to improve how you do things.
And I just want to piggyback on that before Gavi speaks. One of the cool things about the electrocochleography is I found that when I was curling my electrode in the mastoid, for instance, I was getting changes in my reading. So I said, gee, I'm being too rough when I'm curling. So I changed that.
Yeah, I totally agree. It's like things you didn't really expect it should make that much difference. And
now,
again,
whether it makes a difference in the performance or the post-op hearing preservation,
but we know something's happening at the end of that electrode.
Yeah, I've used it a handful of times, but I do think that probably just a slow, sort of gentle insertion is, whether you save hearing or not, is probably an indicator that the electrode's in a good position. So just in itself, it seems like a worthy goal, but we may be a little obsessed with the audiometric outcome beyond what's going to be helpful for the patient. So.
And there is data that says the single most important variable in hearing preservation is insertion speed. There's data that exists that shows that. More important than the size of your cochleostomy, more important than the scala, more important than all that other stuff.
And for my insertion, though, what I do is I try to make I basically try to do it as slow as I possibly can. I try and make imperceptible advancement over as long as possible. I don't even have a time estimate. Yeah, just shaking like crazy. No, but I try and really like.
So what is that? How long is it?
So we actually looked at it, and am I on, Ben? So we actually looked at it, and if you're doing a lateral wall electrode, it's a small perforation, just large enough to get the electrode through, and an insertion time between about 90 to 110 seconds, going along the plane, aiming for the lateral wall. That doesn't displace any fluid, and using the advanced bionics system and tracking this for several cases, and then just looking at outcome, who had hearing preservation afterwards, seemed to be about 90 seconds, and a very atraumatic opening into the round window seemed to be it. So we use it periodically. I'm sure Sarah Love would use it more. We kind of, after using it, realized it was very valuable to teach us how fast and what angle to insert it. So it's actually a very, very good conversation. I think the bottom line is there's just so many things you can do with cochlear implants now that you couldn't do before. What we still don't know is if you preserve the hearing, are they still going to lose it in 6 months or whatever, and what impact does that have? But most likely it really reflects the less cochlear trauma. Doug, anything you'd add?
No.
You're supposed to be up here, by the way.
Oh. I think that my current practice is cochlear products. I don't have the volume that some of you have, so I'll excitedly look at the data that you have. My volume is not large enough to make subtle adjustments and then go back and look at them and see what I did. So I agree, slow insertion for everything. I don't quantify what that is, but I will be mindful of that now. We talked about steroids and things yesterday. I don't add any, just do the perioperative dose of steroids. I don't infuse anything into the cochlea, just mindful with the insertion.
So kind of shifting back, so you all were able to do mastodectomies, or most of you, you've at least gone through a demo looking at middle ear anatomy. So what are some questions you have from this morning? Just fire them at the panel and people can just pass the mic around and answer them. So one of them, so where's Jimmy? Where's Jimmy Prueter hiding? Never mind, we don't want to talk to Jimmy, but go ahead. What questions do you have?
Hungry.
Oh, go ahead, Nate. You're good. No, go ahead. No, you're good. We'll get you later. Any questions? So just starting with Andrew, we'll just kind of work this way. Everybody gets 30 seconds or less. When you're looking at a middle ear for reconstruction, how do you stratify the order of how you do things? How do you plan your middle ear reconstruction?
In my practice, I'm doing chronic ears, and so I'm not really, I don't do stapes anymore or anything with this. So it'll be a chronic ear that's from a cholesteatoma or erosion from a retraction pocket or something like that. And so in my practice, it'll usually be incus and stapes superstructure that are a problem. If it's a conductive hearing loss and it's a stapes and it's like true middle ear, I'll send that to someone that does a lot more of them than I do.
So I'll fan the flames here a bit. This morning on the in the lab, they talked about putting a torp in an ear that has a functional stapes infrastructure, and that is like counter to everything that I've sort of been taught. You know, the cholesteatoma reconstruction literature would suggest that if you have a functional stapes and you build on top with a porp, your hearing outcomes are statistically significantly better than if you're building from the foot plate up. So if I have a stapes, I'm using a porp every time. If I don't have a stapes, then I'm going to use a torp. The other thing that I find that has been really sort of game-changing for my practice is in a really, really nasty ear that's cholesteatoma that I'm going to come back and do a second look anyways, I will put a piece of thick cartilage over the stapes, and I find that a lot of my patients get such a great hearing outcome with that we don't even go back and do a second look. I just do an MRI instead, and if their MRI is clean, now I've got a reconstruction that is never going to fail because it's cartilage and not titanium. So I would say that's one of the biggest changes that I've made in my own practice in the last 5 to 6 years is these type 3 ossicular reconstructions with cartilage do really, really well in some patients. In some, you have to go back, but some of them really get a benefit.
Yeah, I think that's a pretty broad question because when you're looking at a simple, maybe majority of patients that come to me come from internal referrals, and within my practice of 7-8 generally ENTs, and they just get a scan for me every time. And sometimes when they don't even need it with a simple perf, which is a conversation that I've had with them a lot. So I have an idea of what the ossicular chain looks like, what was the history, was it a traumatic hearing loss and things like that. But in the order of how I look at doing things, I always address the tympanic membrane first. I love using cartilage. I use cartilage caps on all of my ossiculoplasties. For somebody with a cholesteatoma, the incus, in my opinion, it comes out. And I do a lot of mastoids with extended facial recess, and picking cholesteatoma off the incus to me just doesn't give me a lot of post-operative outcomes. So I typically get rid of the incus, and I use a porp. I like the Grace Medical Night Bite right now. I like it's kind of got the same thing that the Kurtz had, the little feather things that sticks on the stapes nicely. And then I do a cartilage cap. One of the porps that I really like to have I have at all of my centers is the Frisbee that Grace Medical makes. And it comes into a situation where you've got these porps and they don't go any lower than 2 millimeters, and you've got this really atelectatic middle ear, and next thing you know, you've got this giant prosthesis sitting in there. And so it goes to him like a piece of cartilage. It's got a big surface area on the drum, and it sits right on top of the stapes. I love that prosthesis for the really, really atelectatic ears. Torps, I use what's called a Wildcat Pro. A Grace Medical makes it. It's very easy to put in. Yeah.
My fellowship director used to say the indication for cartilage in tympanoplasty is a tympanoplasty. Tons of cartilage.
So basically generally support what's been said so far, but at the end of the operation, you've got to ask yourself, how satisfied are you with removing the disease? I'm talking about cholesteatoma as opposed to just secretory otitis. I do a lot of children, and sometimes I just abandon the operation. I don't put a graft in, because if I'm not 100% sure that everything is out, the last thing you want to do is not be able to see the cholesteatoma coming back. You've got a child needing an MRI. I used to do second look surgeries. We use the MRI now, but that's a general anesthetic up to maybe 8 years of age. So just step back, do your graft, because what you can do is there's a lovely study from Bristol. They've got millions and millions of data. Dick Moore started it many years ago, and they've shown that a child with a perforation up to the age of 6 or 7 has a huge chance of it will close itself. If anybody's done any retraction pocket surgeries, take it out, it's surprising how this heals up. Even if you don't graft, it's surprising how the ear just heals up. So I try to do a canal wall up whenever I can, because, all right, you might have a little bit more, or they say, residual rate, but I'll use the microscope and I'll use the endoscope to have a check, looking up underneath the scutum into the sinus tympani. But if you've got a little bit of bloody mess, it's not easy to identify congested mucosa from cholesteatoma. So I think all I'd add is graft or not to graft, whether or not it's fascia or tracheal cartilage, but tracheal cartilage is a good workhorse. But once it's there, it's very difficult to see through things. So you'd have to probably rely on MRI, which has got better and better over the years.
Echo all that as well, but assuming all the disease is out, as we're moving on with the case, and mentally you're thinking how to reconstruct. Looking at the defect, thinking, are you going to reconstruct the attic? Are you going to leave the attic open? Are you going to block the antrum? Are you going to make a smaller mastoid defect, or just do a full bore canal wall mastoid bowl? The big thing is I like to look at what the status of the ear was before, meaning if it was an atelectatic ear, mucoid effusion, and you do this beautiful reconstruction and they have terrible eustachian tube dysfunction, they have a propensity to try to undo that. So I have a low threshold of adding cartilage. Trago cartilage, if you're going to do a total cartilage tympanoplasty, conchal cartilage, you can shape the ear. I love the curve of that. It's great to have a nice natural shape to reconstruct the scutum, the canal wall. You can break it in small pieces and have that gentle bow that kind of mimics the posterior pars tensa. But if it started off with a very atelectatic ear, I have a low threshold, if I'm able to put a tube in the post-op period. And hopefully get everything to heal well, and maybe they don't have to have the tube long term, I don't know, but I don't like to have everything suck back and start to undo itself, because then you're left with this long implant and posteriorly, and then this retraction up front, and it's awkward, it can trap debris, and try to avoid that.
I missed the question, but that all sounds pretty good.
I'm not sure I have a lot to add either. I pretty much always use cartilage for tympanoplasties. I don't really see a strong reason not to if the hearing results are as good. I also agree that you have to think about what the likelihood is that your reconstruction is going to survive whatever the middle ear disease was in terms of eustachian tube function. So anything you can do to improve ventilation with what you're doing, I think is helpful. So I also have a fairly low threshold to remove the incus if there's a reason to think that you might be getting better visualization into the superior part, into the attic, or if you might be better able to remove cholesteatoma or improve ventilation into the mastoid. All those things are good reasons to remove the incus. In addition to what Dan said, in terms of the hearing result, sometimes if you want to try to keep the ear from collapsing a little bit without putting a prosthesis in, if you have a healthy incus or have bone that we're not worried is contaminated, it's pretty easy to kind of carve the incus into a small, like a mushroom cap almost, and sit it on top of the capitulum. It's just a way to increase the volume of the middle ear a little bit. And again, decrease the risk of having a piece of something synthetic extrude. And if you're really concerned that they've been through a lot of procedures, that you really are not going to give them, they're not going to likely have very good middle ear ventilation, then I'll just put a shielded T-tube in. So I use a 2mm biopsy punch through the cartilage you're putting in, and trim the T-tube, put it in at the same time, and they'll last for decades. So it's easy to just do it at the same time.
Yeah, I also use cartilage routinely on tympanoplasty. For cholesteatoma, I most often do a canal wall down, and then do a reconstruction of the posterior canal wall with temporalis muscle and bone pate. And then I leave a piece of silastic in after the case, take the incus out, put a piece of silastic over. And then when I come back for the second look, I lift up, and that silastic leaves a nice, sort of like aerates the middle ear, gives you space to get prosthesis, whether it's from the foot plate or on the incus to the cartilage graft.
So I think great conversation. I think a couple of principles that I've picked up. One of them is from spending a couple of days with Robert Vincent in France, and he's the one that convinced me to go from the foot plate with an intact capitulum and arch to the drum. And he actually, on his prosthesis, has a small celastic band. So he puts it in and he puts the band around the capitulum. And he said he's had no tipping, because tipping seems to be the biggest problem with long-term, 3 to 5 year outcomes, hearing outcomes. And so it actually, that prosthesis sits very nicely in between the crura, and it also requires the use of a lot less middle ear packing when you're doing it. And always, I don't do any of these without putting a cartilage cap on it. And the typical thickness is between about 0.5 to 0.7 millimeters in thickness. And if you look at the laser vibrometry data that came out of the lab in Dresden, between 0.5 and 0.7 millimeters vibrates like a normal eardrum. So you can actually run it off the ear canal onto the prosthesis and not compromise your air bone gap, according to their data. And I actually, about 2 or 3 years ago, stopped taking ACUS out routinely. And it was another Robert Vincent comment where leave the ear as normal as you possibly can. So if you've got an eroded, lenticular process of the incus, but the head's healthy, you've got good visibility, you can see around it, and I think your endoscopes let us look around it pretty well. Those lateral incudal ligaments and the ligaments on top of the incus stabilize the head of the malleus. And so you can leave the tensor tympani intact, leave those intact, and I'll just take the laser or a nipper and just shorten the lenticular process, and then I'll put the prosthesis in, and whether it goes under the malleus or is touching it in parallel, the hearing outcomes are the same. The laser vibrometry data was the same in the Dresden study. So I just leave it because it leaves it stable. If I do take out the incus, though, I cut the tensor tympani tendon, because all it will do then is, without any kind of resistance, pull the malleus anteriorly, and that'll tip your prosthesis, particularly if it's under the malleus. So just a show of hands, who cuts the tensor tympani routinely? Okay, who doesn't? Right. So what would make you, real quick, everybody gets 10 seconds. Andrew, why would you cut it?
I mean, the disease, I can't see in front of it to make sure I got all the best.
That plus, I think that if the incus is gone, the tensor pulls the malleus medially, and it can cause collapse of the middle ear space.
I take the head of the malleus out, the incus out, and we could swing the malleus handle around onto the feet, tuck over down with the neck fascia. Same.
Jimmy?
Yeah, I would say that way you can get a little bit longer of a prosthesis in there to have more middle ear space.
Yeah, pretty similar. I think I also like that being able to rotate the malleus so that it's on top of the capitulum. That works pretty well, kind of stabilizes the reconstruction a little bit.
So you cut the tensor tympani and then pull
So
it.
you can rotate it. It's sort of based on the anterior ligament.
Yeah, I mostly like the visualization after cutting it.
Yeah, so Robert Vincent, he will always rotate the malleus. He actually just takes it, cuts the tensor tympani and slides it over and puts it directly on top of the capitulum, whether he has a prosthesis in it or not. And to your point, Mike, that prosthesis, that 2-in-1, actually goes down to 1.4 millimeters in height, which is about what the Frisbee is. And so the whole idea is if you're in an ASC or something, you really just need a prosthesis to do all that stuff. So, and the head's flexible. So any other subtleties in trying to optimize your hearing outcome? And as you look at your outcomes between, like, everybody gets an audiogram at 3 months, what is your follow-up after 3 months to see what your long-term hearing outcomes are? So start here, Gavi. When do you do your first post-op audiogram, and what's your last follow-up?
Well, for a cholesteatoma, the first one is about 3 to 4 months, and after that, I'll see them, every 1 or 2 years. So continue to follow the data long term.
Yeah, just the same, 3 or 4 months. Basically, it's dependent on when I can get them in the clinic.
Yeah, the same. But if I can, I would like to ask the panel their thoughts on an aerating mastoidectomy. So like Gavi pointed out, he obliterates his. If we can continue on that, what are people's thoughts on doing a mastoidectomy for simply a ventilatory standpoint? Obviously, we do a mastoid to get disease, but is there benefit in doing that too? I'd be curious.
So just first the follow-up. I see 3-month follow-up, and then 6 months if it's for cholesteatoma, and then at that point we're deciding what the surveillance may be. Or do they need a second look, or are we going for the MRI? Going for the mastoid, that was the dilemma. I had staff on both ends. Like Pascal's law, you could aerate it, you could have more air now to compress, or you could argue to obliterate, now you have less surface area, but then in the same vein, you could drill the mastoid septa away, now you technically have less surface area, so there's less consumption of gas, so there's less vacuum. So I think I've had people justify it either way, and one of my staff said, well, do you need what's your mastoid numbers? All right, we're drilling to aerate, and the other one would obliterate. So it was, it's controversial. Yeah, I don't have a set.
So Chris, can you sort us all out?
Yeah, I mean, if to go back to cochlear implants, we started off unilateral children's cochlear implants, and Kevin Gibbon, myself, kept on chatting over a pint of beer, said, like, the other ear gets a lot of secretory otitis. Usually dealing with 2, 3, 4, 5-year-olds, which at the typical age group are going to get glue ears. But we just said, look, the number of patients that have got a cochlear implant, you've done a clean, healthy cortical mastoid, very rarely get a problem. You rarely get a glue ear. And then, of course, we're then to bilateral. And the instance of mastoiditis or problems goes against the grain of, you do a cortical and you get sometime a healthier ear. So I did a study of, again, with children doing a cortical with a maringoplasty. And I feel the results are better, but it wasn't statistically significant. I mean, after about 300 or 400 maringoplasties, the take rate was about the same, but you don't get very few complications. But to answer your question, we used to follow them up for 3 years, but the clinics are just stupid, so I'll follow a simple maringoplasty up for 12 months, and the final 12-month audio, but wherever you can get an audiogram. But I think it takes about 6 months for an ear to settle down. So a few bits of the thoughts there.
Yeah, I do the 3 to 4 month post-op audio. If it looks good, then it's yearly after that. If there's a question, the patient may be a little unhappy, then I'll bring them back in another 3 months. To his point, I do tell patients that it takes a good full 6 months for things to settle down. In terms of the ventilatory mastoid, did a lot of mastoids in fellowship, and it adds not very long to the procedure. So if there's any indication of, middle ear mucosa is thickened or the retraction pocket is posterior, I have a pretty low threshold for opening the mastoid and doing a facial recess for that reason. If the perforation is a simple dry anterior perforation and the middle ear looks pretty good, you got to ask, why did they have that perforation? Was it because they fell off a wake? I had a lot of wakeboarding and kneeboarding accidents where I live. What's that? Yeah, grommet. Yeah. A previous tube. When did they have the tube? What's the other ear look like? So I like what you mentioned about the other ear. If the other ear looks a little bit gnarly, then I would have a low threshold for doing a mastoid on it.
We get our post-op audiograms probably between 2 and 3 months, and I sound like I follow my cholesteatoma patients probably a little more closely than the rest of the panel. I tend to have them come back every 6 months for the first 3 years. I think that there's some benefit in keeping them close, especially if they need a second look. A lot of the patients get lost and don't come back until their ear is fungating cholesteatoma. It also allows you, for those who do need a second look, to retain them and start the conversations early. And the third reason, which some people have talked about, is even if the surgery and the reconstruction look good, but their ear starts to collapse, I like to put in a tube sooner than later. So I see them every 6 months for the first 3 years. It's not that bad. Most of them are pretty happy. They're pretty easy patients.
I think the takeaway here is that no one really knows, okay? And you're going to learn from your people that you train under, and that's how you'll make your decisions, because there's not one way to do this. For me, if it's a revision tympanoplasty, if it's not clear-cut that me or someone else that's what happened, I'll usually do some image to see if there's an attic block. I trained under a guy named Newton Coker, and he's had a lot of revisions, and he was very adamant that he thought those ears had an attic block, and that's why the aeration really helped when it was a revision. So I kind of follow under that. I do follow either a tympanoplasty, cholesteatoma I will follow like Dan said, but a tympanoplasty I will follow for 2 years. And again, it's because I have a series of two, and one was a lady that intertympanic cholesteatoma that thought everything was fine, but then it kind of got out of control and got bigger, so she ended up needing a bigger operation, because if we just would have followed, it would have been a really simple thing to see with that. And the other was a young guy that had a bigger problem, but then he developed a cholesteatoma under the flap, and it kind of eroded into the bone, and he didn't come back for 3 years, and then you had to do a mastoid because it eroded in there. So I'm under the Dan philosophy that just follow them. After 2 years, I've not seen a problem with an intertympanic or and these things are really rare, but your name's attached to it, so I think just following for 2 years, I felt really, really safe that nothing else was going to happen at that point. I hope that's helpful a little bit.
So it's interesting. I was invited a few years back to actually address the issue. It was the way this meeting was set up in Greece was they had two surgeons that from different parts of the world that would each be given half of a topic. It didn't have to be your opinion, but you had to defend a position. So it was actually pretty fun. It was like point counterpoint. And in my training, I always became a big fan of Mirko Tos. Like he's written all the books on middle ear reconstruction. It was like God, Jesus, Moses, Mirko Tos in my life. And so Mirko Tos was going to be at the meeting. So I figured this is just awesome, And so I was given aerating mastoidectomy as necessary. And then Rick Friedman from the House Ear Clinic at the time was given it's unnecessary. And apparently Mirko Tos has one wicked hearing loss, because he did not hear the rules of engagement when the proctor of this panel said, this does not reflect the opinions of the surgeon. So I get up and I give this, it was probably, I thought I was actually the best person in the room. I'm kidding. But I get up and I present all the world data, and most of the data comes out of Israel about the whole, middle ear ventilation, mastoid ventilation. And I think to make this more controversial, well, are we really talking about getting rid of an attic block that a middle ear endoscopy could avoid the need for a mastoidectomy, because you really want to keep the surface area of healthy mastoid cells intact for a gas exchange. So the Japanese are actually putting hydroxyapatite back in the mastoid, just seeing if it remucosalizes so they can get better ear ventilation. So they're actually doing a mastoidectomy, then recreating the air cells, which is kind of interesting. So I go back to the TOAST panel, and I give my presentation, and TOAST is sitting in the front row, and my wife, it's the first time she'd ever seen me present, is sitting in the back of a room of about 400 people. And TOAST proceeded to peel me from my head to my toe. Now, the only thing he didn't say is that my mother was a rapist. And I'm sitting at the panel, I'm just taking a whooping from my former Michael Jordan at this point, and I don't know how to stop it. So finally they had to get the Greek host of the meeting to come up and whisper in Tos's ear, like, Professor Tos, it's not his opinion, right? Because he was so deaf, apparently. He just lit me like a blowtorch over this thing, and he thought it was charlatanism, and that I should give my medical license back for such a view. And Rick Friedman gets up after me, and he lays on the table, and he says, drive the nails before I speak. And it was the funniest thing. But it is really, if you get into certain places in Europe, this is not a casual topic on a panel. People are passionate about it. But my argument would be, are we really talking about, an aerating mastoidectomy, or are we talking about a mastoidectomy to remove an attic block? And this is where I think an endoscope may reduce the need to do some of these mastoidectomies, because it seems to me from the Japanese data that by reestablishing surface area, you actually get better gas exchange. So I would do a mastoidectomy for visibility. If there's an attic block I can't get out with the endoscope. And I'm also, I'd love to just scan the panel again on two things. One is I put a lot of cartilage-embedded T-tubes in at the first stage and then leave them there for 6 months. And if they're doing fine, I take them out, because you can always put a cartilage-embedded tube back through the cartilage in the clinic. Some of these people, I end up leaving them in for 2 years, and they really ventilate well. They don't retract. You pull it out, and then you've got cartilage there to protect the drum. So number one, how often use a cartilage-embedded tube? And then number two, to wind the panel down so we get done at 12:45. How do you pack the ear canal after surgery? And I'll be really controversial. I use Bactroban, period. And I see them at 6 weeks. Don't have to take any packing out. And I don't stitch them. I do subcutaneous stitches. Sometimes I'll use skin glue. Sometimes I won't. and I don't even see them for 6 weeks. So that'll be my controversial. So again, how do you pack the ear canal, and then whatever I said before. Go ahead. Okay.
I pack the ear canal with gel foam all the way for every case, and every time I do it, I'm thinking, is there a more efficient way to do this? But it worked, and so it's hard to change. It's working.
I usually pack the ear canal with gel foam. I agree. Try to use as much absorbable things as you can, since I usually do endoscopic. There's not usually, maybe there's an incision for the cartilage, which I just do a 5/0 fast. If I do a post-operative incision, just do skin glue. Yeah.
Do you use cartilage-embedded tubes very often? Are they preventative?
I use cartilage tubes a lot. I've never had the guts to pull one out when they've been doing well for a couple of years. I kind of think, wow, maybe they don't need the tube anymore, but I'm not sure that I ever pulled out one that was working well. If it's not causing me problems, I'm happy to just leave it alone.
And the guy that convinced me to do that, by the way, was Larry Duker.
Oh, to pull it out?
No, to put him in.
Put him in, yeah.
Because a cartilage-embedded T-tube will last for years. I've got people that have had them in for 15 years. So the permanent tube, to me, is a cartilage-embedded T-tube. These osseous-integrated tubes are future infection risk. So go ahead, Jimmy.
I do a cartilage-embedded tube a lot. I wouldn't say it's routine for every case, but certainly if I have concern that they're going to have retraction or recurrence, I think that's totally reasonable. I think that packing the ear canal is a very tedious task, but I recently started using the Stryker here. Stryker makes like an Otopore plug that just fills the whole ear canal in one shot, so it saves some time. I do like doing that. I would like to make that process more streamlined. Maybe I should just do that.
I don't use a cartilage-embedded T-tube or tube very often. I find that either I'll catch it in a post-op and put a tube in if I need to, or put one in beginning, maybe not need to have a permanent one in. I've done a lot of stage 2 balloon dilations in concert with, in conjunction with the canaloplasty or mastoid surgeries. Packing the ear canal, mostly gel foam. If I can get Bactroban or lasagna, a gel foam and Bactroban lasagna. The tedious part is right up against the drum. I might just kind of packing what I need to pack, or and then working quickly as we get out to the lateral canal.
I think packing the ear canal is actually quite crucial. It's not so easy to walk in. You've got to get the flaps back down on.
The flaps back down on your graft. You've got to be careful about how hard you pack, because if you've got a prosthesis in there, you don't want to be subluxing the foot plate into your labyrinth, into the cochlear. So at home we have a very old-fashioned BIP. It's bismuth and paraffin paste. It's on a gauze, and it'll stay in there for months if you want to. But we see them back at 2 or 3 weeks, and the little tapes come out, and you've got a lovely, healthy ear. If follow-up is a problem, so we do the Malawi principle, we use a thing called Otocomb, which is general liquid domestos. It's got a bit of everything, same as Bactroban. It's nice and gooey, and if they never come back, it absorbs. Personally, I use a little bit of gel foam just to stabilize the graft, but that'll just come off and you just leave it be.
How much does your goo cost? The goo you said you injected?
Otocomb? I don't know, a couple of quid for a little vial of, you put it into a giving syringe, and well, same as Bactroban, I presume you just fill it into a syringe and ooze it in.
Bactroban's $6 a tube.
Come to UK.
In terms of the cartilage-embedded T-tubes, I used them a decent amount in revisions before eustachian tube balloon dilation became more readily available, so I've done a little bit less. Business travelers, people that have a tube in the other ear, I like to use a cartilage-embedded T-tube. For the ear canal packing, I'm a lot like Dr. Backus. I usually just do Bactroban. Stapes, I just put a little bit of gel foam along the incision line and nothing else. And then I do use Epifilm a decent amount. If there's, I've done a big canaloplasty, there's some exposed bone, or just it helps protect the flaps. I've got PAs who see some of my post-ops at times, so it helps kind of protect the graft as well. If somebody's a little bit aggressive, although they never debride anything. So Yeah, epifilm and then just Bactroban. Sometimes I'll put an otowick in, especially if I do a big canaloplasty. I'll put a single otowick at the meatus and take it out at 10 days. And incisions, I like monocryl, sub-Q, and skin glue, either one. But actually, my MA really loves taking out stitches, so I just started doing a running Proline, and then she loves taking out the stitches. So, yeah.
I love cartilage and Bennett T-tubes. I use them all the time. I'm a packing minimalist like Doug. I do not use bacitracin just because of some of the literature about granuloma formations. If I do a tympanoplasty, I will also use epifilm over the graft. I'll put 2 or 3 pieces of gel foam soaked in Floxin, and then the rest of the canal is Bactroban. If I am doing a TM intact procedure, I don't use epifilm. I just put, like you said, a couple of pieces of gel foam over the incision, Bactroban in the canal.
I'll say one thing. Kids under the age of 10 don't use an earwick.
I don't use cartilage T-tubes. My thought process is that I can put a tube in the office if they're doing the whole hope is either it's a tympanoplasty or cholesteatoma is that they want a healed ear so that they can get in the water. Again, in Texas, that's important that they can do those kind of things. And so I try and avoid either another hole or something. Sometimes I found if I'm really worried about aeration, I'll use a tiny Titan tube. That'll give me aeration, but it falls out really quick, and there's a very, very small hole, and that'll at least give me some idea, are they going to really retract or not, and will I follow that? Incisions, anyone under 12, it's subcuticular. The other ones, I don't have any problem taking the stitches out. I'm the fan of the packing in the ear, but I do put Floxin solution or on the packing so it's soft when I first put it in with that. All great ideas. I just never use the cartilage tubes.
I just want to say one thing real quick. You know, I used to be very nervous about tubes in kids and swimming. There's actually a great article that was written a couple of years ago now that says that for every kid with a tube, you'd have to put 1,000 of them in the water to have one additional infection compared to a kid with an intact drum. So I have stopped telling my kids with tubes that they can't swim. I've stopped telling my adults with tubes that they can't swim. The only thing I tell them not to do is scuba dive because the pressure is way too much with a tube. But I have zero problem with kids or adults with tubes swimming, diving, ocean, boogie boarding. I just have given up that whole conversation personally.
I'm the same way.
Nope.
I'm the same way. Yeah. I don't want them diving into the pool because, you know, the first 10 feet is a full atmosphere. So that's the most dangerous. And that's where they can suck some fluid in. And I tell them, if you're going to swim, have someone next to you the first few times you swim. And most people, when you ask if they swim, they don't dive under the water. They stay at the surface. So.
Can I ask a really, really basic question? I have no idea how you embed the tube in cartilage.
Sure. So you make a myringotomy. If you have an intact drum, you make a myringotomy. If you are doing a tympanoplasty, it's a moot point. You take a piece of cartilage.
You get right on the wall. It's amazing. I love it.
My kids would be so jealous. So you take a piece of cartilage, tragal, chondral bowl, take a piece of cartilage, and I think someone mentioned it, but I also use a 2 millimeter skin punch, and you punch a little hole in the middle of that cartilage. I use a good T-tube, which the phalanges are really gigantic, so I actually cut a little piece off of each end because they become unwieldy in the middle ear. You take this tube, and I take a little alligator. I put the alligator through here, grab the tube, pull it all the way through until the cartilage is flush against the tines, and then you do just like you would a tympanoplasty.
Dr. Zeitler, do you bevel the opening of the tube?
No.
I just use a 7 suction out of spite to my scrub tech. So he gets mad when it gets clogged.
Same.
Yes.
So why you had to put it on the cartilage instead of just putting the tube? That's what we used to.
That cartilage will keep that tube in for decades.
Even those T-tubes without cartilage, wherever we put, it stays forever.
They have a pretty high perforation rate though when you look at it.
No, not mine either.
It's just one way. If it works, do it.
I will tell you, I have countless patients come in, they're like, I say, oh, your tube's out. Well, my tube can't be out. My doctor said it was a permanent tube. T-tubes are never permanent by themselves. They may last a little bit longer than a grommet if you're lucky, but I really don't find that they last any longer. In fact, I think the length of the tube retention is more based on the middle ear mechanics and the pressure of the patient, and it has nothing to do with these tubes, because I see grommets that have stayed in for 10 years and T-tubes that have fallen out in 6 months.
Yeah. There's no such thing as a permanent tube. I tell that to my patients, but the closest thing is a cartilage embedded T-tube.
So I have additional question about, so are you leaving your perichondrium on your cartilage, or do you then put perichondrium?
No, you typically, I thin the cartilage a little bit just so because it's not.
You have to make another hole in the perichondrium to get that?
So there's one side of perichondrium that's gone. I leave perichondrium on mine.
Yeah, so if I have a tympanic membrane perforation and I'm putting in a cartilage embedded tube, I will leave perichondrium on one side, and that's my graft. That serves as my graft. If it's an intact drum, it doesn't really matter. Sometimes taking the perichondrium off makes it easier to poke through, because that perichondrium is kind of hard to get that skin punch through. But your perichondrium can serve as your graft if you have a perforation.
So Gavi had a question, and then we'll roll at the panel.
So I'm curious, people's post-operative precautions after ear surgery. Starting with Andrew.
Again, it depends on what type of ear surgery did versus if it's a modified radical or radical versus, and I assume the question is, do they have an intact drum with that? What I've found that's work is that they can't do weightlifting or strenuous stuff for 2 weeks. After that, I clear them to do that. For flying, it's over a month before I allow them to fly. And I have these conversations with them before the operation so that they know if they're traveling, so that's what's worked for me.
Can the panelists comment on CPAP too, please?
And wind instruments.
There you go.
And what?
Wind instruments and those sorts of things.
Get them at a band for at least 12 years.
Yeah. No band camp. No band camp this summer. Yeah, I'm kind of a 2-week person too. Again, it's to help me sleep at night. There's nothing out there that says you have to let these patients not fly for a day. There's just no data. But I kind of tell my patients, no one knows the answer, so let's wait 2 weeks, and that way if it fails, you won't blame yourself. I think a lot of the patients feel guilty if something fails, that they did something. I can't tell you the number of times someone comes in, oh, I blew my nose, I didn't mean to. It's like, it's okay, it's probably not a big deal. But so 2 weeks, I'm a fan of that. I have them stay out of the water until the canal is healed. So to me, water exposure is way more important than flying and exercise, because I do think if you get water in a healing ear with some granulation tissue, it's a nidus for infection. CPAP is a really important question, and I don't know the answer. I think patients who have really severe sleep apnea, you're in much worse shape if you take away their CPAP than you are with their graft. So I say try to not use it for 24 hours if you can. If it's mild sleep apnea, I say try to not to use it for 5 days. But again, I'm not going to take away someone's ability to sleep.
Right. Let me think about this for a second. So I say no strenuous activity that would need you to strain for 3 weeks. I say after you start feeling better after surgery, you can start going for walks, no cardio, hit stuff, nothing that's going to get the blood pressure up too much for about 3 weeks. CPAP, depending on the patient, I typically say a week. I have a lot of high school kids in my area. The wind instrument thing is actually interesting. I have a kid who I had to do a revision on. He was a trumpet player. And I originally said 3 weeks, and I've started telling people 6 weeks now, because it actually depends on the wind instrument, obviously. And then sports, teenagers, to me, teenagers are the hardest tympanoplasties to get to be successful. I don't know what it is. 13-year-olds, they don't listen. I don't know what it is, but soccer players, band people, they tend to have a higher rate of failure. And so I'm a little more cautious with them. 6 weeks for me, and then water is 6 weeks.
Since you're talking about pediatrics, what's the youngest any of you will do a tympanoplasty on?
We do them in the womb.
Exit.
Exit procedure. I like, it depends on the patient, obviously. If it's a completely uncomplicated perforation, I wait till they're at least 7, mainly for eustachian tube function, also for post-op care, because trying to clean a 5-year-old's ear in the office is not fun.
This is a huge reason for what Chris said before. Look at their other ear. Yeah. If it's a 6-year-old with a great looking other ear, I'd be way more likely to do that than a 10-year-old with a nasty looking other ear.
CPAP and wind instruments, I really haven't thought of it, because does it make a difference? If you're blowing an instrument, you're actually closing your palate and you're blowing. If you don't close your palate, it's going to come out your nose and you're going to get nowhere. So if you think of Valsalva, it's closing your nose and you're putting pressure into the postnasal space and then hence eustachian tube. But with palatal fixation, eustachian tube's not working. I think CPAP, if you've got a problem with a patulous eustachian tube, you probably haven't got middle ear problems as such. And if your CPAP's that too high of pressure, you've got a problem. But I really haven't even thought about it. I mean, the only thing we talk about, sort of grommets and water, is when we used to have swimming pools in the UK before the power energy crisis came in. I used to say, if you go to Costa del whatnot, you will come back with an infection, because the chlorination, the cleanliness of the hotel pools is a bit dodgy. Go and swim as long as it's a clean. Do you have blue beaches here where there's not much cesspits going out into the sea? Because it's a big.
We have blue beaches.
Poo beaches. Yeah, yeah. But it depends where you are. I mean, kids will be kids. You're not going to prevent. There's nothing that will stop water getting in. And you just tell them, be careful about water and leave it up to them. How many patients are compliant?
What do you think?
I got one here. So I usually tell them, in terms of keeping things dry, I try to convince them to keep their ear dry for a month. Obviously, it may not work, but I at least talk about the risks of infection, and certainly that means no swimming. I don't really talk to them about CPAP and sports. I don't really restrict them on activity. Really, the water's the main thing I'm concerned about.
I tried to standardize the post-op instructions to make it as easy as possible, because there's a wide variety of patients. But I know that there's a lot of people in the mix. Our MAs up front, our nurses calling to do a post-op check. So to simplify it, I kind of have this dogma of, keep the incision dry for a week, keep the packing in the ear until they see me back in about 3 or 4 weeks. No blowing your nose or popping your ears for a month. No flying for a month. Light activity for 2 weeks. Like no heavy weightlifting, straining. Blowing instruments if they ask. And then after the 2 weeks, kind of ease back into your normal workout routines by the time you've seen me back. For the positive airway pressure, CPAP, BiPAP, many years ago, I surveyed otologists, I think 2015, 16, and just asked domestic and international otologists, neurotologists this question. And it was all over the board, the answers. Nobody could agree on what to do after CPAP. Nobody could agree on packing the ears. I think 2/3 of the otologists routinely pack the ear. And everybody was split on the severity of CPAP. Or I guess going back to the hiatus, the average was about 1 week hiatus. I think about half of them were 1 week pause, then 2 weeks. Very small amount didn't look at the settings of the CPAP. When it went to severe OSA, it was split. Some people had about half of the otologists looked at it and said they agreed the severity of CPAP, you do more harm stopping the CPAP, so no hiatus. And then the other half said the severity of CPAP, they're more worried about blasting the middle ear, and so they would try to give a longer hiatus and just be cautious with the sequela of not having the positive pressure on. But the flip side of that is they would over-aggressive pack the middle ear, or more likely to put an ear tube in to maybe just bypass the system and not worry about pressure.
Yeah, so I just tell patients 1 month, no swimming or strenuous activity. So when I talk about strenuous activity, I'm more worried about the gymnastics or the karate or basketball or soccer, where it's like quick movements that could potentially have head injury and things like that. I just don't want the prosthesis of the graft to shift. That's my biggest argument.
And in terms of flying, I routinely operate on people that fly to Alaska and Wyoming, Montana. and I don't really give them a restriction, so we operate on them. They usually fly the same day or the next day. And I have to say that's never been, there have been reasons that they haven't done well for other things, but I don't think it's because they flew. So at least in the short term, I think probably because they have packing in the middle ear, they have blood in the middle ear, probably not a lot of pressure changes happening. Now, maybe I wouldn't be quite as excited if it was a week or 10 days after they had surgery. Maybe there was then some air in the middle ear that might change with pressure changes with flying, but at least in the short term, doesn't seem to be an issue.
Yeah, I just wanted to sort of echo what Cliff said. I think what's interesting is we tell our patients not to fly after tympanoplasty, but we've lifted the drum, we've put it back down, so it's not even going to respond really to pressure. There's no tension in your repair, so theoretically you're at less risk to your eardrum the day after surgery than you are 4 months after surgery. So I still tell my patients not to fly, but I don't have good reasons to tell them that. The other thing that I would say, which, the more you think about why we think we're right, the less it looks like we're right. If you've done a medial tympanoplasty and you put positive pressure, you're actually theoretically opposing the graft to your native drum. If anything, it should help, right? So I don't think we know what we're doing is the point.
So real quick, I think just to summarize, so we've come to a lot of consensus here, as you can see. But I do think that the instructions, from what I'm hearing, and I know in my practice, really reflect, did you do a tympanoplasty, or did you do a tympanoplasty with an ossiculoplasty? Or did you do a tympanoplasty with a ossiculoplasty and a mastoidectomy? I mean, they're all different things, but the basic thing I tell them is you can't fly until you wake up from anesthesia. And you just keep water out of your ear for 6 weeks. That's because I know if you tell them 6, they'll keep water out for 4. And telling people not to exercise to me is like peeing in the ocean to change the pH. They're going to do whatever they're going to do. And so one of the reasons I went to Bactroban is that bacitracin, like Dan said, forms granulation tissue. It also can get stuck in the ear because it's petroleum-based. Bactroban is water-based, and rarely does it ever get stuck. So anyway, thank you, everybody. This is great. And if there's any more questions people have that we can't answer, just let us know. But I think the moral of the story is there's a lot of different ways to do it. You should do what works. And your populations are all going to be different. I mean, my average patient doesn't come from my zip code, so I've got to set them up so they can go home and not have to keep traveling. So this afternoon,